Well, hello and welcome to another edition of Health Solutions with Sean and Janet Needham, where Team Needham discusses everything healthcare. I'm your host, Sean Needham, along with my wonderful wife, Janet, and we are streaming live from the Moses Lake Professional Pharmacy podcast studio. And we are super excited to have Stacey Roberts back on our podcast. She is a physical therapist, and we are going to be talking about pelvic pain, sexual health, and intimacy. And, if you guys follow Janet and I enough, we talk about this subject often, and Janet and I are experts in hormones, so we are good about that part of it. But adding a physical therapist to this topic is huge, because they're going to be talking more about the anatomy and how physical therapists can help that, and we can work in conjunction together. So, Stacey, welcome to our show.
Hey, thanks for having me back. So good to see you guys.
Yeah. So give us a little bit about your history and how you got into this topic and how you ended up on our podcast.
Sure. So I have been a physical therapist for 35 plus years, which is scary to think about. And about 20 years ago, I started treating people with fertility issues, and then got into women's health, and then men's health, and then pelvic floor. So I treat orthopedic and sports medicine, plus pelvic health, sexual health as well too. I recently became a nurse a few years ago to expand my scope of practice. So now I'm obviously more familiar with hormones like you guys, and try to incorporate a holistic view for patients in my practice.
That is awesome. Yeah, I forgot that you're a nurse too. So, wow, what's the next phase of education?
I'm looking at hopefully becoming an NP. We'll see. I'm so busy with work, it's hard to find time for clinicals.
So tell us a little bit about pelvic pain, and let's start with, because I'm assuming, and I'm making that assumption, I'm assuming men have pelvic pain also, but let's go into women first. Mm-hmm. And just talk about what some of the issues are, the complaints that you hear about when women have pelvic pain.
Sure. So, anywhere from your belly button down to your mid thigh, and in that pelvic area, if there's pain, that's technically, could be warranted to see a pelvic health therapist. So what we always say is, where the pain isn't always where the problem is. So even though the pain may be in that area, we might look at your hips or your back. We might even look at the way that you're walking to see how that might be contributing to any pelvic floor issues. And it's not limited to pain, as we talked about before, Sean. It can be incontinence and things like that as well. So any kind of thing that's not going the way that we want it to in that area is fair game for pelvic health. And certainly sexual health and intimacy is one of those things as well too.
So, Janet, I'm sure you have a lot to add to this conversation. You talk to women about this all the time.
Yeah.
So go.
Okay. So, well, I think there is, and I'm reaching out to the women that are in my generation. We were told to take the birth control pill. Mm-hmm. And we were told it was safe, and I'm a pharmacist, so I believe that, and I dispense that. And now I'm seeing women that when they exercise, they urinate, they have leakage, and so it's embarrassing. And so, I know from the hormonal side how I can help them, but let's just kind of talk about what you can offer to ladies that are having leakage.
Sure. I think one of the common misconceptions, although it fits in a certain percentage of people, is that all pelvic health physical therapy is Kegels exercises. So,
right.
So if you have leakage, if you have those types of things, you just need to do your Kegels and then you'll be good. That unfortunately is not true. And what people miss with that is the pelvic floor, it's not necessarily an issue all the time if it's weak. Although if somebody's had a hysterectomy or traumatic, right, or even a normal vaginal birth, there can be trauma there that we need to strengthen. Many times it can be what's called upregulated. So I'm just going to step back a little bit and explain the anatomy. So pelvic floor muscles kind of act as like a hammock on the bottom of the pelvic floor, holding up and supporting all the different structures above that. So for females, it's the uterus and ovaries and, the different structures, the cervix, all those different structures inside the pelvis. And what happens when those muscles become weak, obviously, that could be an issue with being able to use the muscles that are supporting the urethra and that's basically the tube that comes from the bladder that allows us to urinate through. All those things, when they're weak, certainly that could be an issue. So we strengthen those in some types of incontinence and people get better. But there's a good percentage of patients, and men included too in this, that their pelvic floor is actually upregulated. It means hypertonic. It's not necessarily tight like a tight muscle, but it has a lot of tension or tone that is actually too much. So that what can happen is if that muscle's holding on for dear life forever, and let's say a runner goes, or let's say you're doing jumping jacks at the gym, all of a sudden it just can't hold anymore. And then we can lose that tension and create leakage. That's also very significant with things like pelvic pain, like vulvodynia, vestibulodynia. Pain in those areas as well can be due to that really tight pelvic floor. So if you're or really tense or hypertonic pelvic floor, so if you try to contract those muscles, it would be like taking your bicep that's already contracted all the way and then trying to contract it more to strengthen it. It just doesn't make sense, and it can actually make the situation worse. So we do a lot of what's called down training of the pelvic floor. And many people really don't even realize they've got muscles down there that they have control over. So some of it is just making that connection. We all know we can bend our elbows, right? But we don't even know that we have the ability to relax or contract those pelvic floor muscles. And then, longer kind of issues around incontinence is if those smooth muscles that line that urethra that come out of the bladder for us to urinate, if those aren't getting the hormonal support that they need because the patient's in perimenopause or menopause, then those muscles aren't utilized as efficiently. So then we can use soft wave or shock wave to bring more blood flow to those muscles, in combination with hormone therapy, can really shore that up so that patients can get rid of incontinence, and kind of look at the whole package from strength and hormonal support as well.
Wow, that was a good explanation. And I love talking to physical therapists about these issues because I learned so much from you guys. So thank you for that.
You're welcome.
Now, on this same topic, because I heard you mention urethra at least once, what about, and we talked about urinary incontinence, what about, would this type of therapy help to prevent chronic urinary tract infections?
Potentially, right? So there could be an indirect relationship. If somebody has chronic urinary tract infection, my brain goes less to musculoskeletal and more to microbiome, hormones, things like that. However, if again they have some of those issues with the pelvic floor that I was talking about before, that certainly doesn't help. So I wouldn't go directly to only treating, with pelvic floor therapy for urinary tract infection. However, when I use soft wave on women with chronic urinary tract infections, because it has an antimicrobial type treatment where it can kind of get through the biofilm of bacteria, break that up so the body can then heal. I've had women who've had chronic urinary tract infection symptoms for years. I treat them 2 or 3 times with soft wave and then educate them on the microbiome, educate them on optimizing hormone levels, whether it's naturally or with hormone replacement. And most of them don't have any symptoms going forward. One, she's had no symptoms for the last, I think, 3 or 4 years since she was one of my first patients that I treated with soft wave.
I'm just kind of thinking out loud. And it wouldn't, just if you strengthen those muscles around the urethra and the bladder and all that, wouldn't, emptying the bladder, it might be better at emptying the bladder and getting rid of, anything because anything that's left over could be more of a potential to cause infection, right? So,
yeah. So you've got, so the urethra muscles are harder to, let's say, strengthen from the standpoint of their smooth muscles. There's some striated muscles as well through there, but it's less under our conscious control to strengthen that urethra. Not completely, but again, just even more disconnect. So 100%. But also, if I have a muscle that is devoid of blood flow because it hasn't been used for a while because I've had incontinence for a while. So if my biceps was drained of blood and it wasn't working, I could try till the cows come home to strengthen that muscle. But if I don't get blood flow to that area, that bicep is just not going to work. So that's why soft wave and shock wave, true shock wave, works extremely well because it can get deep into those tissues, increase that blood flow so the muscles then have the nutrition they need to work. And then optimizing, like I said, hormone levels as well too, just and optimizing the microbiome, vaginally and, gut-wise. Just the whole package really helps to improve things for sure.
That makes sense. And you got me really thinking now. So, you're basically said in a different way, your muscles have memory, and if you don't use them, you lose them, which we know that with our striated muscle. If we don't use our muscles, they atrophy. And you're saying the same thing happens to our bladder and for incontinence. So in some ways, we should try to put our medical system should try to put off using catheters as a last resort, right? Because once you start doing that, those muscles quit working. Can you explain that?
Yes. And thankfully, the bigger hospitals and the medical systems are doing just that. They're really trying to use catheters less because it can significantly increase the hospital-acquired infection of UTIs, which is, a really big problem. Unfortunately, they were motivated to do that because they started to get decreased reimbursement for more people that they had to treat for that. But I don't care how they got there. At least now they're using the catheters as little as possible. They're still being utilized, but as little as possible. So absolutely. I think it's extremely important for people to understand, because you don't want to keep, injecting bacteria basically into areas that, can't manage that on its own, especially in a compromised system, who's, don't have the good bacteria to support that or, balance that out.
Makes sense. Janet, I'm sure you have some to add. What do you think?
I do. So, now we can, kind of journey into intimacy, because if we're having UTIs, if we're having difficulty there, then you have maybe some other tissue like our vaginal tissue and our cervix. And even for men, we start seeing a drop off in our 40s and 50s and 60s. So how does that play into your role of helping men and women keep that muscle tissue and that area healthy? I mean, I kind of sat in with a physical therapist locally, and I was just amazed at, what she offered. So just share with us so people know that there's other things. I mean, we promote hormones, but there's other things that we can do to help each other in that journey.
Absolutely. So when we're looking at dyspareunia, which is painful intercourse, or vaginismus, which is actually fear of having intercourse after having significant pain with intercourse, we can, if you just think about it, we tense up. If even it just unconsciously, we know from studies that even if before we lift something up, before we actually do it from a muscular point of view and bend our knees, our pelvic floor is already shoring up. So unconsciously, our body's getting ready to do that feat, whatever we're trying to do. Now think about if you've had pain with intercourse, what's the body going to do naturally to protect you? Right. It's going to tighten up. It's going to tense up, like, ooh, we don't want to do that, which then unfortunately contributes to that pain. We've got the biopsychosocial aspect of it, where there's a biological impact. There's that psychological impact and social aspect in regards to, pelvic issues and pelvic pain, which directly impacts intimacy. And then, like you mentioned, Janet, the men who are having issues potentially with testosterone, 40s, 50s, and 60s, if their testosterone levels are lowering, ED isn't always directly related to low testosterone, but it's a potential issue. So now you have both parties in this couple having and feeling bad about the issues that they have towards intimacy. It can be very difficult to connect, and sometimes they don't talk about it. Sometimes the other person doesn't want to, talk to the other person about it. So really, what we can offer too is through education, help people understand that, like you guys do a great job implementing the hormonal aspect of it. We can help with the structural aspect of it. And then both of us, right, can communicate with the patients about that psychological aspect of it, and to open up and talk about it and bring in, mental health professionals if necessary. And utilizing the modalities, like I have SoftWave that helps with decreasing pain significantly. That also can help to increase blood flow for men who have erectile dysfunction, so that they can gain an erection, or utilize a vacuum pump to help, kind of have that workout program at home in between, shockwave sessions. So I think it's understanding how it impacts the relationship as a couple, and also then understanding that there is a musculoskeletal component, there is a physiological component for hormones, and then there is that psychological component. that our society, unfortunately, has been, pushing it to the side and just saying, oh, it's just a part of aging, where it absolutely doesn't have to be.
Right.
Yeah, and that's one thing that Janet and I talk over and over again, that, if because we've heard of women even in their 40s, maybe late 40s, they're going through perimenopause or menopause, and they go into the doctor and they're having painful intercourse, and the doctor says, well, as you get older,
just live
this is just what happens. Sex isn't as important. And I mean, Janet and I tell them straight out, get a new doctor. I mean, if your doctor tells you that, get a new doctor. I don't care if you're 40, 50, 60, 70, or 80. I think it's almost as important with your marriage as water and food. I really honestly do. It's what makes you different with just being friends or roommates. So if you're not doing that, then there's a problem.
Well, I think also, on top of that, it's very taboo perhaps in our society to talk about, this is uncomfortable and I don't like it. And why don't I like it? To have that conversation. And many times we're shut down in the medical community, and there's so many things that we can do to help people. But if that conversation isn't even addressed, I mean, I'm sure most women in peri, and even men for that matter, are not even discussing anything with intimacy with their doctor unless they bring it up. And if it is, it's just kind of like just live with it, right? Which
and those doctors are human beings too, and they have experienced that same taboo of talking about it. So many of them don't have it in their forms. They don't bring it up. They don't think about it as an issue. We talk about this a lot of times in education through pelvic health, is put that stuff on your forms. Even if you're not that 100% comfortable with it, at least maybe the patient can write it down. But hopefully, getting yourself comfortable as the healthcare professional to bring that up. The other part of it is they have 10 minutes with people, right? So it's like, okay, you have this issue. All right, you're not going to have a heart attack. Let's move on. You can deal with that. It's a normal part of aging. Blah blah blah. Let's move on to some more, serious issues. I think that's a disservice that is out there with patients as well too, that they're not getting the time to be able to discuss this with a practitioner that they trust and that can direct them, to someone like a pelvic floor therapist, or to you guys, or a combination, or even a mental health professional to help.
Well, go ahead, Janet.
Well, I mean, that's a great point, because we're really talking about forms of communication, and how I speak to women, and even men for that matter, is intimacy is communication. We're communicating, whether it's words or physical touch, or how we are in that relationship. It is a form. And if it's changing, if it's shut down, then, we need to figure out a way of addressing it. So we kind of touched on it a little bit, that it's on your forms, but how do you approach that with your clients that come to you? How do you, because there has to be a point. I mean, I know on my end how I address it, but how do you address it with your clients to get that door open for making it more comfortable for them?
And I was thinking the same thing, Stacey, because sometimes on those forms, this. Do you have any sexual problems? Whatever the question is. No. But when you start asking them, just kind of going through conversation, you start asking questions. It's like, oh, you have sex once a year. Well, that's probably not good. Something like that. So how do you address that?
So it depends on why the patient's seeing me. For example, I might see somebody for knee pain. I don't necessarily ask them about their intimacy in regards to a musculoskeletal issue. However, what's really interesting is, and I've done this purposely now, is put information around our clinic about erectile dysfunction, about pelvic pain. We did a study on pelvic pain as well too, so that they can, at their leisure, at their comfort, pick that up and start to read it. And as I build that relationship with them, that rapport, they can start to bring it up. Now, if somebody's coming to see me for a pelvic health issue, or it's obviously no brainer if they're coming to me for a sexual health issue, but let's say they're coming to me for a pelvic health, like pelvic pain issue. That just is in my opinion, and in my style of, interactive interviewing when I'm doing my assessment, is to bring that part of it up. Are you in a relationship? Is this pelvic pain impacting your relationship in regards to intimacy? That type of thing. And then, you kind of read the room and see what the patient is feeling comfortable to talk about. And if they do look or seem to be having a difficult time talking about those things, you just leave that door open without judgment to say, look, if
Right.
you are having this issue, I'm here and this is a safe place to talk about it, and then move on to the next thing. So it's more of a normal conversation, not something that seems like it's, out of the ordinary or, weird or, that type of thing.
So we talked about a little bit about men's physical issues, like with erectile dysfunction. So as women age, are there some physical things that go on that a physical therapist can help with? We talked about the vulvodynia, but what are some other things, that physical changes that might happen that a physical therapist can help with?
Sure. Well, Janet brought up earlier about the oral contraceptive pill. A lot of women are on it, still on it, but not necessarily educated in the fact that that can significantly reduce your libido. It can significantly address, affect your microbiome, both of your gut as well as the vaginal microbiome. It certainly can impact hormones as well. Some women who go on it with their estrogen levels are already high can potentially, have issues with it. So I think it kind of really starts there, where we're already setting the tone for developing some other issues, libido especially. But you can see when you look at the vulva of somebody who's been on an oral contraceptive pill, it's very thin, right? The lack of natural estrogen and things like that the body was producing on its own, or even the balance of estrogen and progesterone, it really impacts that tissue. So it can become thinner and more easily damaged through intercourse as well too, which again can lead into that dyspareunia, painful intercourse, vaginismus, kind of fear of having that painful intercourse. So I think we're in a perfect world, where it would start with is, if you're going to go on the pill, these are kind of the side effects and what you can potentially do about it. Keeping track of, looking at your gut health, optimizing your nutrition, all the things that we should be doing anyway. But here's your excuse why, because if you don't really have a reason why to focus on those things, unfortunately, if it hasn't been a part of your life growing up, you typically don't. But if you are educated in the fact that, hey, this could happen and you could head this off at the pass, then potentially there's a really great way to minimize that effects that has. Also, just from a standpoint of, I wish, again, in a perfect world, that every woman who was pregnant or planning on being pregnant had just one visit with a pelvic health physical therapist to talk about, what's going to potentially happen after birth, what you can potentially do to prevent some issues, postpartum. This is your pelvic floor. This is what's going to happen when you have a vaginal delivery, or even if you have a C-section, this is what's going to happen to your abdominals, and this is what you can do instead. So we had some prevention prior to pregnancy, and then some, 1 or 2 visits following pregnancy. It would just go such a long way to help women understand what they can do to support themselves, to minimize the chance of those problems appearing down the road.
So I know when Jan and I had kids, 2 boys, wonderful young men now, 20 some years ago, that was never shared as an option with us. Is that do OBGYNs, do they refer patients to physical therapists before delivery now? Is that routine?
It is absolutely not routine. I would love for it to be routine.
Yeah.
Some will, if they're really into pelvic health and sexual health and understand it, somewhat might suggest it. But I think it should be as common as, I don't know if they're still called Lamaze classes, but I think it should be something that's even discussed in those types of classes as well too, to educate females. I really wish it was a regular part. But I think what happens now, that in our day and age with social media and all this information that people are getting, is patients can ask, right? They can ask their OBGYN and say, look, you know what? I've heard that there can be pelvic floor issues after. Can I just get a referral to the physical therapist? Sometimes if their insurance doesn't cover it, they may have to pay out of pocket, but it would be worth every dime for them to try to minimize impact afterwards, and then, down the line as well too.
Well, from our experience, we've worked with physical therapists all over the country, and you're exactly right. It's worth every dime, and going to physical therapist, paying cash up front is usually not that expensive. Mm-hmm. And it's going to be one of the least expensive things of having a baby, let me tell you.
Right, exactly.
Well,
Exactly.
even just we both, our children were both C-section, and just to help the recovery
Mhm.
would have been amazing for me, right? Like if I look back at it, and even like if I'm looking at my mom who's almost 90, just the things that we can do to help women.
Mhm.
She actually ended up having a hysterectomy, but now she's living with prolapse. She's living with GI issues. She has a catheter. I mean, to me, so many things that we face are preventable or can be assisted and helped by all the modalities of medicine, right? So, I
Absolutely.
mean, to me, I'm like, I don't want to repeat that in my life, because
Mhm.
have seen, how going to having a catheter has changed my mother's interaction with the world.
Right.
Like, her life changed dramatically from jumping in the car and getting her groceries and going to get her hair done, to not wanting to leave her apartment anymore,
Right.
or not wanting to be interactive with people.
Mhm.
So there's, to me, I think that's priceless, that we have things that we can do that can prevent some of this. And even after hysterectomies, there's a lot of changes. Can you address that?
Oh, absolutely. I was just gonna actually bring that up. Thank you for mentioning it, because a dear friend of mine right now is in that place where she is still having a period, occasionally having heavy bleeds, and there's a fibroid, or they think it's a fibroid or polyp, there, and they just want to just whack everything out, just take everything out and be done with it, so she doesn't have those bleeds. And that happens so often, and they forget about, okay, well, if there was a fibroid there, or if there was a cyst on the ovary there, why did that happen in the first place?
Yeah, what's
And
Right.
causing it?
by
Yeah.
removing the uterus and ovaries, yep, she will not have that heavy bleeding again. But that hormonal imbalance will become even worse, especially if it's surgical menopause, and everything kind of bottoms out, right? And then when I looked at her thyroid results, her thyroid wasn't looking great, which could have accounted for some of the imbalance between estrogen and progesterone in the first place. And then that certainly wouldn't change if she had a hysterectomy. So then what's going to happen is that thyroid issue is going to create other problems. So then we create the situation where the woman has multiple issues after the hysterectomy, but the bleeding is gone. Okay, which is
Right.
fantastic. But let's do even an ounce of prevention there, right? Maybe addressing that thyroid, getting it better, optimizing her overall health prior to that hysterectomy. If the fibroids are big enough that she absolutely needs it, out, or Sean and I were talking about, hey, if it's cancerous or there's a significant risk of cancer, yep, take that out. But let's talk about, what you can do for your pelvic floor prior to that hysterectomy, then what you can do afterwards, with the pelvic floor to strengthen it, and, decrease the chance of you having pain, and the prolapse, like you mentioned. And, Sean and I were talking, when you take that, thing out that maybe just is the size of your fist, stuff has to fill in, right?
Right.
You lose some support, even for your low back, not directly, but indirectly. So you're more susceptible to developing some musculoskeletal issues there too, as well. So it just, it just seems so crazy that, with prevention, we'd be able to improve some of those situations immensely.
Yeah, I mean, it's a good point that what you mentioned is that, you know, surgery is, and we talk about all the time with drug therapy, about, a lot of drug therapy, whether it be blood pressure drugs or high cholesterol drugs, they're just treating symptoms of a different problem. You need to fix the problem, not just treat the symptom. And
Right,
a hysterectomy, taking out a hysterectomy because you have irregular bleeding, is not, it's fixing a symptom. It's not changing the problem.
right. Yep, exactly. And there are certainly cases where hysterectomy is fine and warranted, and I'm not, certainly not against them. What I am against is just taking it out, not thinking about why it happened in the first place, besides the presence of these structures, which, well, why did the cyst happen? Why did the fibroid happen?
Right.
None of those things are even considered. And when you bring it up, literally, they're like, oh, that doesn't matter. They'll be gone. So, we'll take care of that along with it too. But it does
Well,
matter. It matters a lot.
Right.
it matters on so many levels, and I'm sure that our clients and listeners have heard us talk about that. But there's so many women that I feel, as we age, kind of get disregarded after even having hysterectomies because, you know, their difficulty is just like, get over it. Here's an antidepressant. Get over it. Here's
Right.
anxiety. Here's, you know, and what they're really displaying is something physiologically as well as, you know, all the other things that are happening to them. And I don't,
Yep.
I guess what I don't, I would like to change this. You know, we love to educate people on this. I think a patient or, you know, as a woman and even as a man, knowing what is in front of you and making those decisions that are important. But what is your take on how we get the medical system and healthcare providers to get on board with this? Because I can't tell you how many times a day I hear, well, my doctor just wants to give me an antidepressant. And I don't think that's a fair answer to these women. I think it's really a knee-jerk reaction, like they don't really know what to do. So here you go. And that creates a whole slew of other problems. So how do we get the shift in our industry, you know, as providers to get on a different level? What's your view on that?
So there's a great organization called ISHWISH, the International Society for Women's Sexual Health. So International Society for Women's Sexual Health. So if you're a provider out there listening to this, look up ISHWISH, get involved because they talk about all these exact things that we're talking about here and the importance of it. The other way is getting you to approach your providers about it. So if you're a consumer listening to this, talking to your providers about it, getting them to open, you know, getting a conversation going about it. And if they aren't supportive, then looking for another provider, which isn't always easy. I totally understand that. I'm not being flippant about that. It can take a few providers to find the right person that's for you. So it's really important to be able to kind of look at it from both. But I think if the public starts to present these things and then even, you know, present things from the standpoint of what research is out there, because research, you know, is certainly available to anybody who can, you know, use a keyboard these days, and present that to your providers. And hopefully you have a provider is open to listen. But again, you know, getting involved with, you know, many of the things that now there's almost, I don't want to say too much information, but there's so many different rabbit holes that then consumers who don't have a medical background can kind of go down. So it's really trying to find trusted people that they can go to discuss these things and help them. Some functional medicine providers may be an option as well too, but the problem we end up with there is, and you guys I'm sure see this all the time, is just because somebody's low in estrogen, progesterone, testosterone doesn't mean they need estrogen, progesterone, testosterone, all three things at once, because one converts into the next. And, you know, so we want somebody who understands the hormonal cascade and can help to, you know, address how the hormones react with each other, right? So we're out there. It's just a matter of, you know, when you're a consumer, it's hard to find those people. So I think those things are really important. And to your point about giving an antidepressant, I'll just tell you a really quick story that I will never forget. I listened to this lecture about 30 years ago, and the gentleman was an gynecologist and obstetrics doctor. And he said he was so excited about doing this fellowship under this really world-renowned gynecologist and obstetrician, where he had to, he listened to the lecture from him. And the guy said basically when they were in the emergency room and dealing with these patients, or if the patient came in the emergency room, the doctor went into the closet and put an antidepressant in one pocket and a birth control pill in the other pocket, and then would say, if they have a uterus, give them the birth control pill. If they don't have the uterus, give them an antidepressant, basically no matter what their issue was. So that's where it was 30 years ago, and it's very similar to that today. But we do have organizations like ISHWISH to help providers think much more outside the box in order to help with those types of things.
Yeah, and on that same subject, I heard another story like this. A doctor who kind of saw the light later on. He was an OBGYN. He said the way he was trained was if they're less than 40, birth control pills. If they're over 40, hysterectomy. And that's essentially kind of what we've done with women for the last 30 years.
Yeah, exactly. And I am so sorry to do this, but this is the weirdest thing that's never happened to me. But we have the police outside who said there's a bomb threat in our office, and we have to evacuate the building. So I just,
oh my gosh, that's exciting. Well,
This is crazy. I am so
this
sorry.
is crazy, right?
I'm so
Well,
sorry.
Stacey, actually, it's perfect timing because we're winding this podcast up. So,
Okay.
Stacey, thank you so much. Your knowledge and wisdom is so impressive. We love having you
Thank you.
on. We should have you on again. We
I would
love
love it.
what you bring to our podcast.
And hopefully the building will be here when I come back.
Right?
Yes,
Yeah.
right.
So
Right.
evacuate.
So
Take care
thank you.
of yourselves. So good to see you guys. And thank you again for allowing me to be a guest.
Sounds good. Thank you so much. And listeners and viewers, thank you for tuning in to Health Solutions with Sean and Janet Needham. Tune in Thursday to our regularly scheduled podcast, or I'm sorry, for our midweek podcast. 8 a.m. The bomb threat's kind of freaking me out, so I'm kind of stumbling a little bit.
8 a.m.
I'm glad I'm glad Stacey's okay, and she helped us realize our goal of this podcast, which is to educate and empower individuals to take charge of their own health. So tune in Thursday to our midweek podcast, 8 a.m. to 9 a.m. Pacific Standard Time. Thank you all for listening and watching.